मात्रै छ एकछिन 3 को एक्ज्याक्ट तपाई गरिनुस् न तपाई चाहिँ गर्दिनुस् कि हामी चाहिँ पर्खिन्छु नि
The slide is live now.
Okay.
One minute. Ten seconds. Start. Start करता हूँ सर.
We are just waiting for a few more. Hello, good afternoon to everyone. We are just waiting for a few more participants to join and we'll start the session shortly. Thank you. Hello everyone and welcome. Myself, Mrs. Anila Jordan Bhutia, Assistant Lecturer, Sikkim Manipal College of Nursing from the Department of Obstetrics and Gynecological Nursing. I'll be your host for today's webinar. Thank you for taking the time to join us today this evening, as today we are going to discuss about COVID-19 and pregnancy. So when we talk about pregnancy, it is a very special event, not only for the life of the woman, but also it is for the entire family. It is usually mixed feelings are there, emotional challenges are there. So there are so many things that is going to pile up together. So there's a beautiful saying that there's no better feeling than the moment of life inside you. So how beautiful it is that, right? But sometimes, it does not work the way we plan. Now, because of this pandemic, it has shattered the life of people all over the world, and it has also affected pregnancy. So I believe that today's session is going to be quite exciting and interesting ahead of us. So let me tell you the objectives of today's webinar. That is, by the end of the session, the participants will be able to know the effects of COVID-19 during pregnancy. They will be able to identify the high risks in pregnancy, understand testing, treatment, vaccines, and breastfeeding in pregnancy during COVID-19. So now I would like to request Mrs. R.K. Rupaya Sadab, Associate Professor, Sikkim Manipal College of Nursing from the Department of Obstetrics and Gynecological Nursing, to kindly introduce our resource person for today's webinar. Over to you, madam.
Good afternoon, all and one present here. I would like to give a brief introduction of today's speakers. So our first speaker is Dr. Enu Boro. She is an assistant professor from Regional College of Nursing. And ma'am has a vast experience in teaching. She worked as a nursing tutor at Downtown Hospital Guwahati and Regional College of Nursing. She was also working as a professor cum principal in charge at CPMS College of Nursing for 5 years. And ma'am, presently she is the assistant professor at Regional College of Nursing Guwahati. Ma'am was also a resource person during the training programs on HIV/AIDS and ART, training for nurses under the Global Fund to Fight AIDS, Tuberculosis and Malaria. Madam was also a resource person for NCC under NHM at Regional College of Nursing. And ma'am, she's also a research guide for both graduate and postgraduate students. And ma'am, she has published many papers both in national and international journal, index journal. So ma'am, we welcome you to this webinar. So our second resource person is Professor Binita Khati. She is the professor and head of the Department of OBG Nursing at Sikkim Manipal College of Nursing. And Madam Binita has done her BSc Nursing from Sikkim Manipal College of Nursing in the year 2005 and Master in Nursing in OBG Nursing from Rajiv Gandhi University 2009. And Binta Madam has a teaching experience of more than 16 years. And yes, ma'am, she has multiple responsibilities both in the college level and university level. She's also a admission officer. So if anyone is interested for your friends, your family, your sisters, for the next session, you can approach madam. You can take her email ID and all. And yes, ma'am, she has so many responsibility and she is a member of many committee in the university level. And she is also the executive committee member at Sikkim Nursing Council and a chairperson of the examination committee at Sikkim Nursing Council, Sikkim. And ma'am is the member of Trained Nurses Association of India, TNAI, and a Society of Midwives India, SOMI. Madam has published many papers both in national and international index journal, and yes, she has also presented papers in the conference and national and international. And yes, Madam has been awarded at the SMU Pride for Excellence Teaching in the year 2009. So, Madam, we welcome you to this webinar. So
Thanks so much, Mrs. Arki.
Yes, okay, my pleasure. So these are the brief introduction of today's speakers. So thank you so much. Anila, over to you.
Thank you, Madam Arki, for your kind presence and for introducing us to the experts of today's webinar. So before we start with the session, there are a few instructions for the participants. Your mic will be kept on mute so that we can prevent any kind of distractions or any background noise. If you have any queries or any questions, you can post it in the chat box. We will redirect your questions to our resource person, which will be addressed at the end of the session. Feedback form will be given a few minutes before the end of the webinar. Filling of the feedback form is mandatory to get your e-certificate. I repeat myself, it is mandatory to get your e-certificate. E-certificate will be provided 48 hours post-webinar. So let us begin with the first session today, which will be dealt by Dr. Inu Boro. Ma'am, she will be mainly talking about the effect of COVID-19 in pregnancy and identification of high risks. Over to you, madam. You can share your slide now. Ma'am, you can share your slide. Ma'am, your mic is on mute.
Yes. Is it visible? Is it visible?
Yes, ma'am. Yes, ma'am.
A very good afternoon to everyone. Hopefully all of you are doing well. So I am Dr. Inu Boro, working as an assistant professor at Regional College of Nursing. The webinar for the COVID-19 and pregnancy has been adopted in a view to introduce some of the concept of COVID-19 and pregnancy in today's events. Without any delay, I would like to share the slides to all of you so that you can see. First of all, I know that all of you are familiar with the COVID-19. So I would like to give a brief introduction.
I'm so sorry to interrupt. Excuse me, ma'am.
Yes.
Ma'am, can you please put it in slide share mode, please?
It's not sharing.
Slideshow mode.
Ma'am, we can see your slide, but it is in not slideshow mode. You can put it in slideshow.
Yeah. Can I proceed with myself also?
Yes, yes.
I will click by myself.
Yes, yes, ma'am. Yes, ma'am.
Okay. So first of all, I would like to give you a brief introductions, and along with this, I am
sorry, ma'am.
Yes, yes.
No, it is not showing in slideshow, ma'am. Down that slideshow button is there. No, you can click on that slideshow. Yes, down.
Where?
Down there.
On the right side. On the right side.
Yes.
Down, ma'am.
Yeah. Here.
Towards your right, ma'am.
Towards my right.
Yes, ma'am. Slideshow. Yes, down there.
But here only.
No, ma'am. Down. That 68% is written. No, ma'am. 68% is written.
8%.
Yes. Next to that slideshow is there.
This one?
Yes, ma'am. No, down. You come this side, ma'am. Slightly. 68 is written, no?
Yes,
which
ma'am.
one?
Vijay,
is it my slides are not visible?
Ma'am, slides are visible, but it is not in
slides are
slideshow.
visible. We can see your slides, but at the bottom right hand side, you can see you can increase the size of the screen. Below that, there is an option called slideshow. Please click on that. No, bottom, ma'am. Right hand side, bottom.
Yes, there also she can go. No, she can go there also. Slideshow, resume.
Or she can just press F5 from the keyboard.
Yes, ma'am. You can press F5 on the keyboard.
Okay. Coming. Is there any problem?
Ma'am, or else you can go to the slideshow option and then you can click there, ma'am, from the beginning.
From beginning?
Yes.
Ma'am. Can I proceed with now?
Ma'am, you need to click first, ma'am.
Slideshow. Ma'am, click on slideshow from beginning.
So I have Sujan. Then from the beginning, this is the one.
Yes, ma'am.
Like this way, shall I proceed?
Okay, ma'am, you can continue, ma'am.
Okay. So first of all, I would like to give a brief introductions and regarding the COVID-19 and pregnancy, and along with this one, I am going to touch a little bit with the global scenario and national scenario. So all of you are familiar what is COVID. So COVID stands for Coronavirus Diseases 2019, which is a viral respiratory tract infection caused by a new variant of coronavirus named as SARS-CoV-2. This is severe acute respiratory syndromes coronavirus 2. The World Health Organization, WHO, was alerted about several causes of pneumonia of a new viral origin from Wuhan City, China, on this 31st December 2019. So in March 2020, the World Health Organization declared a global pandemic of COVID-19 caused by SARS. As of July 2021, there have been more than 185 million confirmed cases and more than 4 million deaths reported worldwide. So COVID-19 pandemic has one of the biggest public health emergencies for mankind. Transmissions of the viruses is known to occur through close contact with an infected individual or from contaminated surfaces. The virus can also be transmitted from person to person in the pre-symptomatic phases and from asymptomatic individual. So the adverse effects of COVID-19 pandemic on maternal and perinatal health are not limited to the morbidity and mortality caused directly by the disease itself, but also include the challenges faced while services are pregnant in unfavorable circumstances like lockdown and unprecedented demands on the health system. So further, the risks of acquiring COVID-19 from infected pregnant women poses unique challenges to healthcare personnel in providing antenatal care. As per a study conducted by NIRRH and ICMR in India, the case fertility rate.
Excuse me, ma'am.
Yes.
I'm so sorry to interrupt.
Yes.
Ma'am, your slide, no, it is not moving. I mean, it is not changing. So, ma'am, can you please once again unshare, then again share, ma'am? Because your slide, no, it is not changing. Only first slide we can see. Yes, now it is changing.
Okay.
Now
First,
it is
I
changing.
will cancel, then. Now?
No, ma'am.
Is it changing?
Ma'am, just cancel once, then please share once, ma'am. Once again.
Okay. I will cancel first. Yeah, I will first cancel, then again I will share.
Yes, ma'am.
Yes. Is it coming?
No, ma'am.
No, ma'am.
This is for sharing, isn't so?
It's not. I think you have to share once again, ma'am. Click on that button, sharing button, and upload your slide once again, ma'am.
Okay. Now this is coming?
No, ma'am.
Is it coming?
No, ma'am. Just a second, I think. Let's try. Not yet, ma'am. We can't see the slide. Ma'am, can you share it the same way that you have done before? Yes, ma'am. We can see the slide now.
Slides are there.
Slide, yes, ma'am. We can see the slide. Ma'am, you can just click on the slideshow option.
Okay, from current slides?
Okay, yes, ma'am. From current slide, you can do that. Ma'am, can you click on that?
Can you, is it visible?
Yes, ma'am. Ma'am, can you try to change the slide now, if it is changing or not?
Oh, I think I have to change.
Oh, yes, ma'am. You need to do it yourself, ma'am. Can you try it once?
Yeah, I will do.
Okay, ma'am.
Is it coming?
No, ma'am. The slides are not changing.
Not changing? Okay, from your side also you can.
Ma'am, maybe I'll request control.
Not changing?
Ma'am.
Yes.
Ma'am, you can remove your slide. I will upload from my side and I'll change it. Okay, you can continue your presentation, ma'am.
Okay, definitely. From your side only you upload?
Yes, ma'am. You can remove your slide.
Okay, I am removing. I am going to stop sharing now.
Yes, ma'am.
Yes. Yeah, I have stopped.
1 minute, ma'am. 1 minute.
Okay.
Anila, is it visible? Anila?
Yes.
Yes, ma'am.
Slide is visible, no?
Yes, ma'am. The slide is visible. Yes. Slideshow. Okay, done.
Okay, ma'am. Which slide I should go, ma'am?
Third. You proceed with the third slide.
Yes, ma'am. Ma'am, just say next. Okay, I will change the slide.
Okay.
Yes, ma'am. You can continue.
Okay. So COVID-19 pandemic, just previous slide. From the third, again, previous slide. Yes. Okay, next. World Health Organization, finish next. Yes. So COVID-19 pandemic has been, previous slide. Okay, the COVID-19 pandemic has been one of the biggest public health emergencies for mankind. Transmissions of viruses is known to occur through close contact with an infected individual or contaminated surfaces. The viruses can also be transmitted from person to person in a pre-symptomatic phase and from asymptomatic individual. Next slide. The adverse effects of COVID-19 pandemic on maternal and perinatal health are not limited to the morbidity and mortality caused directly by the disease itself, but also include the challenges faced while providing services to the pregnant women in unfavorable circumstances like lockdown and unprecedented demand of health system. Further, the risks of acquiring COVID-19 from infected pregnant women poses unique challenges to healthcare personnel in providing antenatal care. As per study conducted by NIRH and ICMR in India, the case fertility rate among pregnant women and postpartum women was found to be 5.7% during the second wave, which was significantly higher compared to the first wave when your case fertility was only 0.7%. It shows that during the second lockdown, it was higher compared with the first wave. During the second wave, it was more compared with the first wave. Next slide. Rates of severe coronavirus diseases 2019, COVID-19, that is intensive care unit admission and maternal mortality increased among pregnant and postpartum women admitted COVID-19 in the second wave compared with the first wave in India. So in the second wave, it was more compared with the first. Next. There is now growing evidence that pregnant women may be at increased risks of severe illness from COVID-19 compared with non-pregnant women, particularly in the third trimester, and symptomatic maternal COVID-19 is associated with an increased likelihood of iatrogenic preterm birth. So it shows that like your during the third trimester, and if the mother is having symptomatic COVID, that time there is chances for the baby to have some medical related illnesses in case of preterm babies. Next. So a study published in the Lancet Global Health 31st March 2021 found that maternal and fetal outcome have worsened during the COVID-19 pandemic, with an increase in maternal death, stillbirths, rupture, ectopic pregnancy, and maternal depression. The review includes 40 studies, and 3 of which were from India. COVID-19 present an immediate emergent challenges to the healthcare system. So this is published in Lancet, and like it shows then COVID-19 pandemic in worsen the fetal and maternal conditions, especially in relation with the maternal death, stillbirth also, rupture ectopic pregnancy also, and in case of maternal depressions. Next. So come to the next slide, that is your risk factors. Generally, we can say there is a very low risk in case of complications during the time of pregnancy. So next slide. The overall risk of COVID-19 to pregnant women is very low. Already I have mentioned that COVID risk factors in case of pregnancy and complications of pregnancy, it is very low. The risk factors of severe severe diseases and death in pregnancy include older age, that is above 35 years, obesity, pre-existing medical comorbidities such as hypertension, diabetes, asthma, heart diseases, HIV, chronic liver failures, kidney or lung diseases increases this risk. So if the mother is having like some comorbid factors already which I have mentioned, or mother is above your elderly primary gravidia, or age is above 35 years, so obese mother having diabetes also, in death cases the risk for death and like some other problems it may occur during the time of pregnancy periods, or it will be more. Next. Some research suggests that pregnant women with COVID-19 are also more likely to have a preterm baby and cesarean delivery, and their babies are more likely to be admitted to a neonatal unit. So nowadays for COVID also lots of research studies it is going on. So many people they research study on the COVID. So based on the research studies, so it shows that those research studies shows that like pregnant women suffering from the COVID, there is chances to have preterm baby, and even such cesarean chances also it is more. Then even for the newborn neonates also, if mother infected with the COVID, then baby also likely to be admitted in the neonatal unit. Next. Effect of COVID-19 on pregnancy. So pregnancy does not increase susceptibility to coronavirus infection, but appears to be worsen the clinical causes of COVID-19 compared with non-pregnant women of the same age. So pregnancy actually it is not increasing the risk of like a susceptibility to COVID infection, but it may make more problem if we compare the pregnant women with the non-pregnant women. Next. Although most above 90% of cases, infected pregnant women recover without undergoing hospitalization. Rapid clinical deterioration can occur, and symptomatic pregnant women appear to be at increased risks of severe diseases and death. So 90% cases, above 90% cases, though they are infected with the COVID-19, but without hospitalization only recovery is there. But sometimes that condition it is sometimes that if the sign and symptoms it worsen, that during that time there is a risk for severe death, severe diseases, and even death also. Death may take place. Next. On account of lockdown situation and isolation, perinatal anxiety and depression, domestic violence may increase. The pregnant women may require additional mental health supports. Next. So transmission. So how that COVID it is transmitted from one person to another person, all of us we are aware, but here I am going to specially mention about which is from mother directly from the baby during the maybe the antenatal period or the intrapartum period. So with regards to vertical transmission, emerging evidence now suggests that vertical transmission is probable, although the proportion of pregnancies affected and the significance to the neonate has yet to be determined. Next slide. At present, there are no recorded cases of vaginal secretion being tested positive for COVID-19, and at present there are no recorded cases of breast milk being tested positive for COVID-19. So lots of, I said already mentioned, like lots of research study also it is going on, but vaginal secretions and breast milk, it is like till now it is not recorded, or there is no result that this research result shown that Kobit this vaginal secretion and breast milk is tested for the COVID positive for COVID-19. Next slide. Effects on fetus. So there are currently no data suggesting an increased risk of miscarriage or early pregnancy loss in relation to COVID-19. So there is no such data at present. So there is no evidence currently that viruses is tetragenic long-term data is awaited, and COVID-19 infection is currently not in indications for medical termination of pregnancy. So like COVID-19, already I have mentioned, like no data, just data. Till now we have no data has shown that there is increased risk for the mother, for the baby, regarding the early loss of the baby, or even like there is no indications that if the mother is having COVID, she has to go for medical termination of pregnancy. There is no just indication. Next. So clinical presentation of COVID infection in pregnancy. So the sinus symptoms which we are finding for the COVID-19, like it remains same as the general population. The like incubation period, it will take place for 5 to 7 days. Then fever, it will be more than 38 degrees centigrade. And there will be the presence of dry cough, sore throat, difficulty of breathing, and sometimes shortness of breath, and even the gastrointestinal symptoms also it can see, especially the diarrhea. Diarrhea also one common cause for COVID-19. Next slide. So the specific obstetric management, all of us, we know that for when we are managing antenatal mother, the history taking, it is one of the most important part of that. So while taking the history, everything we have to collect, as because for COVID-19 now, especially in the medical field, we are going to ask more questions for the from the mother to obtain some informations. So for this, a detailed travel history, a history of exposures to people with symptoms of COVID-19, present symptoms of COVID-19 for the mother, and coming from hotspot area or immunocompromised condition. All these things we are going to ask from the mother. Next slide. So pregnant informations to be shared with pregnant. So information whenever the mother is coming to the antenatal OPD, or this information we can give information regarding the COVID-19, or the ASA workers or ANM or any health personnel. Whenever they are meeting a pregnant lady, they can share these informations to them, or they can just give they can give one hello educations to a pregnant lady regarding or COVID-19. So if she is infected with COVID-19, she is still most likely to have no symptoms or mild illness from which she will make a full recovery. Next slide. If she develops severe symptoms or her recovery is delayed, this may be a sign that she is developing a more significant chest infection that require enhanced care. So she should contact her maternity care team immediately. And there may be a need to reduce numbers of antenatal visit, however, not to reduce her numbers of visit without agreeing first with her maternity team. So we can tell her, like, if she is having mild or moderate symptoms, so no need for like you're coming to the coming to hospitals or for hospitalization. At home only she can go for isolation, and if she is having severe symptoms, that time we can tell her, like, most probably there may be Chinese infection also, so she should talk to her healthcare team immediately based on that matter. And like she has to first consult with her maternity team or gynecologist regarding her numbers of antenatal visits. If like her we all of us, we know that there should be 4 antenatal visits for a lady during her pregnancy period. So at least if she can reduce during that COVID period, so she has to talk with her maternity team first based on that. after discussion, she can reduce the number of visits. Next. Thus, and do nots for obstetric care providers in COVID-19 pandemic. So if a woman meets criteria for COVID-19 testing, she should be tested first. And until test results are available, she should be treated as though she has confirmed COVID-19. If first thing is that when if she is meeting that this is COVID-19 first, that time she has to be tested first. But we should not wait for that COVID-19 COVID positive or negative results. If she needs treatment, immediately the treatment has to be provided for her. And do not delay obstetric management in order to test for COVID-19. So if some urgent obstetric management, this one obstetrics for the lady, then first it has to be take place. Next. Elective procedures like inductions of labor for indications that are not strictly necessary. These all are not that much strictly necessary. Then routine ultrasonographic scans, not for a strict guidance-based indications, and routine investigation should be reduced to minimum at discretions of care providers. So based on the your how to say based on the care provide decision, like this ultrasonography or some routine investigation, it can be reduced or it can be delayed. If there is like a COVID positive, COVID positive for a pregnant lady, and if ultrasound equipment is used, it should be decontaminated after use. Suppose after using the ultrasonography, if suppose emergency ultrasonography is needed for a mother, during that time, if the mother is COVID positive, that time the ultrasound equipment has to be decontaminated with 1% of hypochlorite solutions. Next. Obstetric units should take into consideration. So, isolation of pregnant patients who have confirmed COVID-19 or are person under investigation. Basis and refresh training for all healthcare personnel to include correct adherence to infection control practices, personal protective equipments, use and handling. Actually, these things like infection control program, it has to be continue in the hospitals. And sufficient and appropriate PPE supplies. It should be there in the hospitals, and processes to protect newborn from the risks of COVID-19. Next. Come to the antenatal care. All of us, we know that antenatal care from the conception time to till the time of delivery, the care which we are giving to this antenatal care. So, if there is COVID, or for the COVID pregnant woman, what type of care we are going to take. So this one I am going to discuss in details. Next. Next slide. So Government of India has mandated that a pregnant woman needs to have at least 4 antenatal checkup along with at least one Pradhan Mantri Suraksha Matritva Abhiyan visit during second and third trimester, including a ultrasonographic scan. According to WHO also, like lady should get at least 4 antenatal checkup, and 1 antenatal checkup, it should be done by the medical officers. And nowadays, this is also in second or third trimester, ultrasonography also this is included. At least 1 ultrasonography, it is included. However, it is emphasized that this is only a minimum requirement, and that more visits may be necessary depending on the woman's conditions and needs. So this is like minimum requirement, like 4 antenatal checkup, at least minimum the mother should get. But depending on the condition of the mother, that requirement also it may be more also. Suppose if the high risk mother, she might actually she should get more than 4 antenatal checkup. So if she needs more than 4 antenatal checkup, that time she has to go for she has to go for her antenatal, to visit her antenatal checkup. Next. The suggested schedule for antenatal visit is as follows. First visit, it should be within 12 weeks of gestation, or as early as she is getting the positive results for her pregnancy. Then second visit, it should be between the 14 and 20 weeks of gestation. Then third visit, it should be between the 28 and 30 weeks of gestation. And fourth visit, it should be between the 36 weeks to till the term of the that fourth visit, it should be there. Next. The woman should be advised to attend routine antenatal care tailored to minimum at the discretions of the maternal care provider, unless they meet current self-isolation criteria. So it's based on the care provider also. They can make it minimum also. So for women who have had symptoms, appointment can be deferred until 7 days after the starts of symptoms, unless symptoms become severe. So if a woman is having the symptoms, that time she can postpone her antenatal visit until and unless the symptoms it subsides. Next slides. If needed to visit health centers, should take own transport or call 108 or 104 or 106, informing the ambulance staff about her status. For women who are self-quarantined because someone in their household has possible symptoms of COVID-19, appointment should be deferred for 14 days. So if someone is infected, that time the appointment, it should be postponed till 14 days. Next slide. So additional antenatal checkup visit may be planned at the discretions of the maternal care provider if there are any specific symptoms or danger signs related to pregnancy. Additional visit if the mother is needed. Suppose if she is having some danger sign, during that period, she has to discuss it with the healthcare providers or gynecologists. And then gynecologist only he or she will plan regarding the pregnant lady. Additional that antenatal checkup. Then encourage the patients to visit nearest primary health center or sub-centers. If having any danger sign, that time she has to visit to the primary health centers or sub-centers. Next. Whenever a pregnant woman visits a facility for antenatal checkup, she should examine on priority and segregated from the routine patients waiting for their appointments. Fixed day approaches for antenatal checkup in a week may be adopted, and adequate IEC to be done prior. So, thing is that if she is coming for antenatal checkup, that time if possible she should be segregated from the other patients, and there should be prior appointment she has to take, but it may be over phone also, telephonic also. Then like 1 week prior she has to take appointment for the antenatal checkup. Next slide. Women should be consulted that if she tests positive for COVID-19 during pregnancy or immediately before pregnancy, she shall have to, before delivery, she shall have to deliver at a dedicated COVID facility center only. So medical officer in PHE or maybe CHO may arrange a teleconsultation of the patient with the obstetrician at the hub as and when required. Where if she is in the Kobit facility centers, so that medical officer or in that PHE or maybe CHO also, they can arrange. Community health officer also can arrange the telecommunications with the obstetrician for the patients in the COVID facility centers. Next. If a pregnant woman develops symptoms like fever, cough, difficulty in breathing, or flu-like symptoms, she shall inform the concerned ASA and ANM or CHO who shall further promptly inform the medical officers and block medical officers. So she can, if having showing any symptoms, immediately she has to inform ASA or ANM or CHO and ASA, ANM or CHO, so that they can inform it to the medical officer, those who will be present in the PHE or maybe in the block medical officer, so they can, so that they can inform. So sampling of chest cases for COVID-19 shall be done, and assessment of high risk pregnancies shall be criteria for deciding whether the sample shall be taken from home or under observation in an institution. So again, high risk, this is high risk assessment also, it should be done, so that if the mother is in high risk, she has to be transferred from the home to the maybe COVID center or maybe in an institution, hospitals setting. Next. Any woman who has routine appointment delay for more than 3 weeks should be contacted. It should that contact like ANM or ASA or community health officer, they can contact by telephone, or routine household visit also they can go for. And if when they are going to visit the pregnant woman, they have to put PPA. Next, like even if a woman has previously tested negative for COVID-19, if she presents with symptoms again COVID-19, then it should be suspected. If like previous, if it is negative also, again symptoms are there, then it should be suspected for the COVID positive. Next slide. Referral to antenatal ultrasound services for fetal growth surveillance is recommended after 14 days following the resolutions of acute illness. After subsiding the illness, after 14 days, like your one ultrasonography, it is very important to know the fetal growth. The service provider can assess the feasibility of isolation of the patients at home, especially if in slum or small household, else she could be admitted in hospital or quarantine facilities. If like if facility for home quarantine at home it is there, so she can take home quarantine also. If the homes are very small and like your in the slum areas, that time during that period, if like facilities. Am I audible?
Yes, ma'am, you're audible.
Vinita?
Yes, ma'am.
Vinita?
Yes, ma'am, you are audible. Yes.
Hello?
Yes, ma'am.
Hello?
Hello, ma'am. Yes.
Ma'am, you're audible. We can hear you, ma'am.
Hello?
Ma'am, we can hear you.
Okay, okay, thank you. Okay, okay, thank you. So previous slides, go to previous slides, Vinita. So yes, like it's in case of slum areas, that pregnant lady, if she is infected with COVID-19, she has to be transferred to the quarantine facilities. Next. Next slide, Benita. Also self-quarantine for close contact of the pregnant patient tested positive for 14 days, and whether she has attended antenatal clinic in the last 14 days before testing. If so, self-quarantine of the service provider. But nowadays in our places it is not there. Like if we are like any person, any care provider or any health workers, if we are not going for any these things like quarantine at present. We are now to in Assam. We are not having any like from 15 February. Government has withdrawn every like COVID-19 protocols and all. Only like if someone is infected with COVID-19, that time only the person will get 7 days quarantine, and after 7 days, even if some symptoms subside, no need of doing COVID testing also. But in case of schools and in case of your college levels programs, it is very mandatory in some institutions. If a patient tests positive, she should be advised to deliver at least at the first referral unit, preferably at tertiary hospital. If positive, that time in tertiary hospital she has to deliver. Next, antenatal visits and care in women infected with COVID-19. No additional tests are required in asymptomatic or mild symptomatic cases, and routine appointment, especially for growth scans, antenatal care appointments, are delayed until after the recommended period of isolation. Next. Pregnant woman is counseled regarding danger signs of pregnancy. Actually, this counseling is for everyone, every pregnant woman. Pregnant woman is counseled for self-monitoring 4 times a day, like pulse, temperature, oxygen saturation, difficulty in breathing, and home isolation.
Hello, ma'am. I think it's network problem.
I think it's a network problem.
Yes, ma'am.
Ma'am, are you there? Hello, ma'am?
Ma'am, I think it's a network.
Yes, yes.
Yes. There is some network issues. We're just going to fix it. Sorry for the inconvenience, dear participants. Actually, there was some network problem. Ma'am is trying to rejoin again. Please have some patience.
Vinita ma'am.
Just hold on. Ma'am.
Inu ma'am, there?
Yeah. I don't know how come it automatically it was disconnected. Okay, just you show me the slides.
Okay, ma'am.
Okay, the self-monitoring slide, self-monitoring, self-monitoring, the symptoms and sign and symptoms she has to symptoms she has to check, like temperature, heart rate, then this oxygen saturation, and then about the feeling, breathing, and any other if she is having. So 4 hourly she has to check, and heart rate and oxygen saturation with pulse oximeter. She can use it nowadays. It is also it is available in the market. So 4 hourly, like 8 a.m., 12 a.m., 12 p.m., 4 p.m. and 8 p.m. she can check it. Next slide. Next slide, Vinita. Vinita, next slide. So tips for home isolation. So she has to go for, if she is going for home isolation, some tips are there. So place of stay, well ventilated room, preferably attached washroom, avoid sharing of personal items with other people in household, and cleaning the surface in the room that are touched often with 1% hypochlorite solution to be ensured. So bleaching powder, if she takes 6 teaspoons of bleaching powder in 1 liter of water, so she can make it 1% hypochlorite solution, and with the whole surface she can clean it. Next slide. So respiratory and hand hygiene. So triple layer medical masks she has to use, and masks to be discarded after 8 hours, and it should be earlier if it is wet, then followed respiratory equities. So frequent hand washing with soaps and water for at least 4 seconds, or clean with alcohol-based sanitizer. Next. So medications and other interventions, then dehydrations, hydrations and balanced diet, raised in prone or lateral position, left lateral position, especially for pregnant lady. All of us, we know these things. Then symptomatic treatment for fever, running nose and cough, and warm water gargling and steam inhalation twice a day. This is like very important. Gargling and steam inhalation in case of COVID patient, it is very, very, very important. Next. If fever not controlled with a minimum dose of tablet paracetamol 650 mg 4 times a day, consider other drugs like NSAID, like tablet naproxen 250 mg twice a day. So non-steroid drugs she can go for. Then inhalations. Budesonide, it can be taken by 80 microgram BD, so it is for 5 to 7 days. For persistent cough, if there is persistent comes and it's beyond 5 days of illness. And self-monitoring she has to go for already. How she will go for the self-monitoring, the chart I have shown you. Next, antenatal contact after recovery from illness. After recovery from illness, like recovery from infection in first trimester, considered one obstetric ultrasonography during pregnancy between 18 to 22 weeks of pregnancy at a part of routine antenatal care. So soon after recovery from this one, COVID. If the mother is pregnant, in case of pregnant woman, that during that period, soon after recovery of the COVID, after 14 days, she has to go for one ultrasonography to know the fetal growth. This is very important, especially in the second trimester and the third trimester. Recovery from infection in later half of pregnancy, consider sonographic assessment of fetal growth 2 weeks after infection if required. Next slide. So pregnant women having flu symptoms tested negative and no obstetric intervention required, she shall be home quarantined till the symptoms resolve. Next slide. Referral for antenatal ultrasound services for fetal growth surveillance recommended after 14 days after resolutions of acute illness. Next, for women self-quarantine because of some household has probably symptoms of COVID-19, appointment should be deferred for 14 days for antenatal visit. So again, she is going to postpone her appointment for 14 days. Advisory for antenatal women. So disinfections of surfaces to reduce fomites related spread. Already I have said 1% hypochlorite solution. She has to disinfect all the surfaces areas. For women walking outside the house, it is probably to do work from home. If she is walking outside house, then if possible that work from home should be there, and keeping a distance for at least 1 meter in various necessary interaction and activities. If it is not possible, she has to go for office during that period. At least 1 meter distance it should be there while doing interaction with the other people. Next. Avoid non-essential travel. If travel is undertaken, it preferable to use a private vehicle. Avoid gathering and functions to celebrate the 7 months milestones, which is a very common cultural practices, and minimize visitor from coming to meet the mother and newborn after delivery. So we are celebrating some rituals or common cultural practices at 5 months and at 9 months. So if it's possible, this should be avoided. Next. Telemedicine for pregnant women during COVID-19. The importance of telehealth for maintaining the provisions of essential maternal and newborn health services during COVID-19 pandemic has been highlighted by the Ministry of Health and Family Welfare in the guidance note on provisions of reproductive, maternal, newborn, child, adolescent health plus nutrition services during and post COVID-19 pandemic, released in May 2020. Next. Advantages of consultations using telemedicines: provide consultations to the pregnant woman who is COVID-19 positive, who having no or mild symptoms. Telephonic triage can be conducted to identify pregnant women who requires in-person visits and thus avoid unnecessary hospital visit. If possible, only telephonic triage it should be there. If a pregnant woman requires testing for COVID-19 infection, the virtual or telephonic trials may aid her in getting to the right facility lab. Here we are having 104 for telephonic conversations, so she can go for it. Furthermore, for COVID-19 positive pregnant women with mild or moderate symptoms, a suitable advice regarding the disease management can be given utilizing the same platform by the concerned medical officer specialist located in the distance. Referral linkage and taking pregnant women to the nearest COVID facilities can be facilitated for the pregnant women with moderate to severe diseases. Next. Facilitate routine antenatal checkup, follow-up, not warranting a physical or a manual par-vaginal examination, and routine sharing and interpretation of lab reports. Informations on danger signs in pregnancy and birth preparedness discussion. Next. Ongoing pregnancy risk assessment. If risk identifies potential and acute complications more frequent, contact need to occur, and this may need to face-to-face conversations. Next, healthcare providers at the subcenters or PHC can schedule a telehealth appointment with a gynecologist in case of a high-risk pregnancy. They can take an appointment with a gynecologist before a face-to-face visit, thus limiting the time requirement for the consultations during the face-to-face interaction. So prior to that, that health providers or those who are sitting in the those who are at the subcenter or PHC, they can schedule the appointment with the gynecologist for the lady before the face-to-face visit. Next. Educate pregnant women about preventive measures during a pandemic, self-care, detections of danger signs, reassurance, and maternal well-being. We have to give good educations regarding all. Next, antenatal care during the last trimester require prioritization. Telephonic contact should be made ASA or ANMs with known high risk pregnant women to ascertain their status and organize home-based follow-up if necessary. So ASA or ANMs, they can go for it. So they have to prioritize, especially in the last trimester, because during this is the very less precious time for a lady. So they have to organize everything whenever it is necessary for the lady during the third trimester. Next. Drugs during pregnancy. Use of low-dose aspirin or other non-steroidal anti-inflammatory drugs, NSAIDs. So it can be, it is generally it is using, so no change is recommended because this is using for the pre-eclamptic cases. So however, due to the importance of low dose aspirin in preeclampsia prevention, low dose aspirin should be continued to be offered to pregnant and postpartum women as medically indicated. If it is medically indicated, they can continue. So there is no changes for the, there is no recommendation for changing it. Next slide. So use of magnesium sulfate. Now we are using for the magnesium sulfate for eclampsia and preeclampsia cases. So the risks of eclampsia should be balanced against the risks of respiratory depression. So we know that if we are using the magnesium sulfate, so chances of respiratory depression also there is. So we have to find out, we have to balance the both risks, even the eclampsia also, even the fits also, and even the respiratory depressions also. So by balancing, for balancing this one, only 4 grams of bolus dose of magnesium sulfate will work. We have to give only 4 grams of bolus dose of magnesium sulfate. Next, use of antenatal corticosteroids. So corticosteroids we are using at the 34 weeks of gestations. So generally we are using your beta-methason or dexamethasone as a corticosteroids. We are giving it at 34 weeks of gestation, or we are giving 34 means 34 to 37 weeks of gestation. If we are finding any preterm labor, during that period only we are giving. So no changes in recommendation here. We corticosteroids we can go for only because of the lung maturity of the baby. Then tropolitic drugs, we can use, generally we are going for if a woman is using the tropolitic drugs, there is like in general there is contraindication in case of Kobit suspect or confirmed cases, but this also it is depend on your this is gynecologist or like medical officers, depend on the medical officers whether the tropolitic drugs like your Duvadilan, the as for example Duvadilan, whether the mother will use or not during the COVID period or in suspected COVID cases. Next, intrapartum care. So the intrapartum care we are considering from the true pain onwards to till delivery of the placenta and membrane, and after that till 2 hours we are considering the whole. It is in intrapartum care. So under intrapartum care, next slide. Ensure safe institutional delivery, very important. Only institutional delivery should take place. Maintain due list of all pregnant women with expected date of delivery in next 3 months for active follow-up. So it is very important to maintain a list of all the pregnant women. So each pregnant woman to be linked to appropriate health facility for delivery by the ANM, CHO or MO. So all the each pregnant woman, they should be linked appropriately with the healthcare facilities for the delivery of the baby. Next. All districts should identify and communicate the peripheral facilities, a list of functional and staffed COVID hospitals. Availability of dedicated ambulance for COVID and non-COVID patients must be ensured at the district or block level. So assessment of severity of COVID-19 system, which should follow a multidisciplinary team approach, including an infectious disease and medical specialist. Next. General guidelines. All women, despite the pandemic, have a right to have safe and positive childbirth experiences. Informed consent, it is very important. In addition to routine consent, it would be prudent to include aspect related to COVID-19 infection for the time of the pandemic. Even for COVID also, one in consent, it should be there during the pandemic period. Next. Minimize the number of people involved in any procedure, and a single asymptomatic birth partner can be permitted to stay with the woman at a minimum through pregnancy and birth. Only one person, those who are asymptomatic or having the negative COVID results, they can stay with the mother, and standard universal precaution to prevent contact with body fluid need to be followed, and biomedical waste management as per protocols has to be maintained. Next. Labor timing of delivery. So COVID-19 infection should not dictate timing of delivery. It cannot dictate the timing of delivery, except the cases where the potentials for rapid deteriorations in maternal respiratory status or maternal life is at risk. If there is rapid deteriorations of maternal respiratory status, and if that maternal life is at risk, any complication is arising during that period only, emergency delivery, it will take place. Otherwise, COVID-19 infection is not going to dictate the timing of the delivery. For women with suspected or confirmed COVID-19 early in pregnancy who recover, no alterations to the usual timing of delivery. So if there is no problem, then there should not be any alterations for the delivery timing. Next. For women with suspected or confirmed COVID-19 in the third trimester, it is reasonable to attempt to postpone delivery till they recover, provided no other medical indications arises. If suspected case or confirmed cases in the third trimester, and if like delivery date is there, but see, she has recovered and she has to wait for a few days, that time it can be delayed or it can be postponed. If there is no any serious matter, if it is arising. Next. Intrapartum monitoring. During that period, what are the things we are going to monitor? Like, besides strict monitoring maternal and child well-being, with partograph, generally all of you know that in that labor room we are using the partograph. We are monitoring the maternal and child health. We are monitoring the process of labor, progress of the labor with the help of the partograph. Beside to that, periodic evaluations of respiratory status also, it is very important for us. Then symptoms of difficulty or shortness of breath, this is also an oxygen saturation with the help of pulse oximeter, and it should be this is monitor hourly, and it should be more than 94%. Next. Then prolonged labor should be avoided. Always remove during the this is if the mother is suspected case of COVID, or maybe the mother is COVID positive, that time there should not be a prolonged labor. Early decisions for cesarean section should be taken in case of prolonged labor. If that prolonged labor is prolonged or delay during that period, so decisions should be made for the cesarean section. So intervention should follow standard obstetric practices. Next. Mode of delivery for COVID-19 confirmed cases. So mode of birth should not be influenced by the presence of COVID-19 unless the woman respiratory condition demands urgent delivery. Already I have mentioned. So COVID-19 is not an indication for cesarean section. Again, COVID-19 is not an indication for cesarean section, because all of us, we know, like some, if the mother is having, suppose as for example, placenta previa, abruptio placenta, or maybe the cephaloperevic disproportions, or having some your neonatal aspects, some like problem, fetal distress and all, during that period cesarean section, it is very urgent. Otherwise, COVID-19, it is not indication, it is not there, and inductions of labor and cesarean delivery should continue to be performed as indicated. So induction of labor, suppose we are going for the induction of labor, or maybe we are going for the cesarean section, whatever indication it is there for it, that only we have to go through those indication only, not that COVID-19, based on COVID-19 positive cases. Next. Birth companion. So the birth companion may be allowed as per the state's COVID SOPs, and should have a negative COVID-19 certificates. Already I have mentioned also, those who will accompany with the mother, she or he should have COVID-19 negative certificates. Moreover, the same person should remain with the parturient throughout labor and immediate postpartum period. In some hospitals, inside the labor room, birth companions are not allowed, but in some hospitals they are allowed. So if like a person is allowed, only single person is allowed, that time he should have negative certificates, and that person only he will be with the lady during the time of intranatal period, also during the time of postnatal period. Next. So flowchart for management of COVID-19 in pregnancy. So this is for the flowchart. So pregnant women with COVID-19 exposure, so travel to an affected country within the previous 14 days or close contact with a confirmed cases of COVID-19. That one is if she is close contact with a COVID positive cases less than 1 meter for more than 15 minutes and living together. She is staying with the person togetherly and direct contact with a body fluid. If it is so, then there should be a clinical examination or investigation should be there. So RT-PCR or maybe your repeat test, it should be done. So if RT-PCR, if this is case is asymptomatic, then no isolations room, and only at home we have to monitor the case. That is also then temperature and the respiratory symptoms, it has to be monitored. And if the case is symptomatic, that time if fever is like your more than 38 degrees centigrade and the respiratory symptoms also present, that time that case has to be transferred to the hospitals and or maybe COVID centers and isolated room preferred with the negative pressures. This is and protective gear for visitors and personnel, health personnel or PPE they have to wear, and delivery and neonatal procedures equipment on the sides. So delivery and neonatal procedures, whatever equipments or articles it is needed, it should be in the site of the mother, in the room, in that particular room. Next. So previous line is monitoring at home. So next line. So we are monitoring at home and we are monitoring the continuation of the previous slide, only this slide also. We are monitoring at home and we are monitoring at the hospital. So when we are monitoring at the home during that period, if we are finding suppose reports already came out and it was found negative, so that time no need of monitoring anymore. So if that report is coming, suppose asymptomatic cases but report is coming positive, then again home isolation for 14 days. So if during these 14 days if she has delivered, so breastfeeding also it will be as per guidelines, then mother will be isolated from the newborn until the viral setting of the it gets cleared. Then if she has not delivered, if she has not delivered, then ultrasonography it should be done to know the growth of the fetus after 2 weeks. Okay, after 2 weeks again ultrasonography it has to be done. Next is your at the hospital setting, if your COVID-19 if COVID result RT-PCR if it is coming negative, then isolation at home for 14 days and their hair also clinical monitoring it should be there. So if symptoms persist, then again it should be retest. Most probably there will be your possible false test also. So if that results, if it comes positive, then hospitalization in a tertiary centers. So maternal for maternal surveillance, it should be temperature should be checked, then heart rate, blood pressure, respiratory rate, everything. Then X-ray also it is important by guarding the with the seal. Then next is your fetal heart rate. It is very important, fetal monitoring and fetal maturation also. Here betamethasone injections to the mother it has to be given. So depending on maternal states, especially around your 34 to 37 weeks of gestation, and antibiotic also it is given as per protocol. Next slides. So intensive, in case of hospital setting, intensive care unit admission. So here, systolic blood pressure, it has to be if it is less than 100 mm of mercury, respiratory rate if it is more than 22, and Glasgow Coma scale if it is less than 15. That time, intensive care unit admission, it is must. Then, and in case of your severe failure, organ failures. So delivery before 24 weeks of gestation, if severe maternal illness, consider MTP. If it is 24 weeks of gestation, if the maternal condition is deteriorating, that time MTP. Now it is legalized. Now after that, after 24 weeks, so IRNP and like vaginal delivery, if possible, induction of labor, or maybe instrumental delivery, maybe your venous delivery, maybe your forceps delivery, and early clamping of umbilical cord and cleaning of newborn. So like nowadays, delay clamping of the umbilical cord, but in case of COVID-19 positive cases, our early clamping of umbilical cord and separation of the baby immediately, and separating the baby from the mother. It is very important. And newborn, and we have to monitor the newborn in IRNP. So again, and we have to test for COVID for the newborn. So this is also RT-PCR. Then breastfeeding with due precautions and consideration again, and mother isolated from newborn until the viral shedding resolves. So my mother also should be isolated from the baby. Next, postnatal management. Here, next slide. So all of us, we know that by the management, soon after like delivery of the baby and placenta, we are considering this is the postnatal area term till the 6 weeks. So the care which we are providing to a pregnant lady, this is the postpartum periods or postnatal care. So it is unknown whether the newborn with COVID-19 are at increased risk for several complications. Transmission after birth via contact with infectious respiratory secretion is a concern. Facilities should be considered temporarily separating the mother who has confirmed COVID-19 and in PUI for her baby until the mother's transmission-based precautions are discontinued. Next. Consideration below for temporary separation. The risks and benefits of temporary separation of the mother from her baby should be discussed with the mother by the healthcare team. A separate isolation room should be available for the infant while they remain a PUI. Next. The decision to discontinue temporary separation of mother from her baby should be made on case-by-case basis on consultations with clinicians, infection prevention and control specialists and public health officials. Discussion should take into account disease severity, illness, signs and symptoms, and results of laboratory testing for viruses that causes COVID-19 and SARS-CoV-2 of mothers and neonates. Next. If collocations, this is sometimes we refer as your roaming in of newborn with his or her ill mother in a same hospital room occurs in accordance with the mother's wishes or is unavailable due to this is facility limitation. Facilities considers implementing measures to reduce exposure of the newborn to the viruses that causes COVID-19. Next, consider using physical barrier. Example, this is curtain between mother and newborn and keeping the newborn more than 6 feet away from the ill mother. If no other health adult is present in the room to take care for the newborn, a mother who has confirmed COVID-19 or is a PY should put a face mask and practice hand hygiene before each feeding or other close contact with her newborn. Next. The face mask should remain in place during contact with a newborn. This practice should continue while the mother is on transmission-based precaution in a healthcare facility system. Next, breastfeeding. During temporary separation, mother who intend to breastfeed should be encouraged to express their breast milk to establish and maintain milk supply. If possible, a dedicated breast pump should be provided. Prior to expressing breast milk, mother should practice hand hygiene. Next. After each pumping session, all parts that come into contact with breast milk should be thoroughly washed and entire pump should be appropriately disinfected. The express breast milk should be fed to the newborn by a healthcare giver. If a mother and newborn do roaming and the mother wishes to feed the breast, she put on a face mask and practice hand hygiene before each feeding. Timing of the choice. So depends upon need for monitoring and hospital care as decided by the doctors and availability of home isolation facilities. Follow the revised discharge policy for COVID-19 by Ministry of Health and Family Welfare, which is updated from time to time. Next. So like mild diseases or asymptomatic cases are discharged within 2 to 3 days. So next, like 2 to 3 days, and if it is cesarean section, 3 to 4 days, and moderate and severe symptoms in patients. Then say till the symptoms she has improved her symptoms, and 10 days after appearance of the first symptoms, and at least 3 days of a febrile period without the use of antibiotics. Just previous slide. Why I have said like 20, though it is written here 24 to 48 hours like that, but within 1 day we are not giving in like in our government setting also this for antenatal mother they are not giving, for normal cases also they are not giving the charges. At least they are giving 2 to 3 days. 2 days it is compulsory. On the 3rd day only generally the mother is there, they are getting the charges. That's why I have mentioned, like though it is written like in that from the Ministry of Health and Family Welfare, but like we are in hospital setting, especially in the government hospitals, they are giving 4 to 3 days for normal delivery. Next slide. Counseling and advices at the time of discharge explain danger signs related to both postpartum period and COVID diseases. So danger signs, especially the mother may suffer from PPH also, puerperal sepsis also. So we have to tell her regarding the danger signs of it and regarding the COVID diseases also. To observe COVID appropriate behavior and necessary precaution at home, and teleconsultations number to be provided. Sometimes she can go for these things. Tele advices also. Next. Slide. Next slide. So teachers' recommendations. Discharge for postpartum women should follow recommendations for discharge of hospitalized patient with COVID-19. That is when tests are negative and maternal and neonatal condition should be stable. Then only like discharge she will get discharges, and stable neonates exposed to COVID-19 and being roomed in with their mother may be discharged together at the time of mother's discharge. So if the baby is negative but mother is positive, till togetherly only both of them they will get discharges from the hospital at the same. So now I am coming to the conclusions of my ending part. So the large majority of women who contact COVID-19 during pregnancy will be asymptomatic or suffer only mild diseases. The risks in a small subset of women who develop more severe diseases, however, are not significant, with increased rates of intensive care unit admission invasive ventilations and preterm birth when compared with the non-pregnant population. So, proven therapies should be offered to the pregnant and breastfeeding women as in non-pregnant populations. Admitted women should receive multidisciplinary care with input from senior decision maker and early escalations where required. Women planning pregnancy or those currently pregnant should not be denied the COVID-19 vaccinations. So this all about my topic. And I'm extremely sorry to all of you because due to like I am having some network problem at my area also. So due to like network problem, you have faced I think a little problem. So I'm sorry for that. So anything anyone would like to ask? Any queries do you have?
Ma'am, we have few questions in the chat box. Since we are running out of time, ma'am, we will do it at the end of the session, if it's okay, ma'am.
Okay.
Thank you so much, madam, for sharing your information and your expertise. It was very clear. I'm sure that everyone is going to share this information to your friends and family who are still not aware about it. Okay, so moving on to the second session for today's webinar. When pregnancy comes in picture, people are very reluctant, you know, when they come to know like they have to get vaccinated or if there's any use of medication, they usually hesitate. So when the COVID-19 vaccine started for the pregnant women, people, they were hesitant to take the vaccine, okay? And some of them are still not sure about it. So because of this, confusion has been created. So in order to enlighten you all with the information to clear all your confusions, today we have our very own Professor Vinita Khati. Ma'am, I request you to kindly take over the session.
Thank you, Anila. You can see my slide?
Yes, ma'am.
Okay, so Dr. Inoboro has elaborately told us about what COVID is, what is the relation of COVID with pregnancy. So now, without touching that, I would like to come to few questions that pregnant women have during pregnancy. So I am pregnant. What healthcare should I expect during COVID-19? So most of this has been answered by Dr. Inoboro, that at least 4 in-person visit during your pregnancy from your midwife or doctor, or other visits can be done remotely. Then a pregnant woman is eligible for respectful care during birth. Then newborn care and postnatal care she should get without any problem. Then access to family planning, counseling, and other sexual and reproductive health services. Then she is eligible to get mental health counseling and care also. Now we have learned about what is COVID-19, how it has been spreaded, how we have to manage COVID-19. But before that, we know that we have to undergo certain tests for confirming COVID-19, that whether the person is positive or she is negative of COVID-19. So we will just look at what are the testing strategies for COVID-19 in pregnant women. So a healthcare worker and health facility should always adhere to the ICMR's latest testing strategies, which is updated from time to time. So we have to always adhere to ICMR guidelines that COVID-19 test has to be done earlier. It was very much strict that RT-PCR has to be done. Now we slowly we have seen, we'll see in later slides also. Then in hospital setting, all pregnant women admitted for any obstetric indication should be tested for COVID-19 by RT-PCR. If RT-PCR is not available or in case of emergency, then RAT, that is rapid antigen test, can be done with approved kit. Nowadays we can see so many kits are available that we can do rapid antigen test. But hospital settings and all, they should not use any rapid antigen test which is not approved by ICMR or WHO. So WHO has approved the rat kit, which is standard Q COVID-19 antigen test kit. So this only is a standard rat kit which has to be used in the hospital settings. Now, algorithms for COVID-19 test interpretations using rapid antigen point of care test. So if someone is having rapid antigen test, and if that test says that you are positive or a pregnant woman is positive, then irrespective of symptom status, it has to be reported as positive. We hear so many people that how I am positive because I don't have any symptoms. But irrespective of any symptoms, the person, if it is in the test is indicative of positive, then that person should be considered as positive only. Then if rapid antigen test is negative, then we have to categorize that whether the person is symptomatic or asymptomatic. So if the person is symptomatic, either with fever, cough or sore throat, then definitely send sample for retesting by RT-PCR. And if the person is asymptomatic, then the person, 1 minute, the person turns symptomatic, then only the repeat test or rat has to be done. Otherwise, he or she will be considered negative. So all positive and negative test result should be entered into the ICMR portal on a real-time basis after performing the rapid antigen test. So once by rat, if it is positive, then we have to consider that person as positive and it has to be entered into the ICMR portal. It is recommended that all pregnant women reporting to health facility for admission should be screened and tested for COVID-19. However, it is important to note that no pregnant women should be denied immediate care on the basis of non-availability of testing facility. So if a woman comes to a center where there is no testing facility available, that center should not deny of care if she is in requirement. So that center has to provide the care irrespective of the test is done or not. Now there are certain advisory for COVID-19 testing and admission which is patient-centric. RT-PCR must not be repeated in any individual who has tested positive once either by rat or RT-PCR is confirmed as positive. We can hear presently I am in a group of CRH where we have to inform that the person is positive, and sometimes we get a query that how I am positive because I don't have any symptoms. Can I repeat the test or should I do the next after 3 days and all? So once the person is tested positive, he or she will be considered positive and test should not be repeated. No testing is required for COVID-19 recovered individual at the time of hospital discharge in accordance with the discharge policy of MOHFW. During the current upsurge of COVID-19 cases, any individual presenting with fever, with or without cough, headache, sore throat, breathlessness, body ache, recent loss of taste or smell, fatigue and diarrhea should be considered a suspect case of COVID-19 unless proven otherwise by confirmation of any other etiology. So sometimes if the this also we have seen that people say I am having headache, cough, but this is because of the change in the weather or change in the climate. So they don't want to go for testing. So if those kind of patients are there, if those kind of mothers are there, pregnant women, then we have to treat them as suspect case of COVID-19 and test has to be done. Then positive test for COVID-19 virus is now not mandatory for admission to COVID health facility. earlier, if you have to go to COVID-19 healthcare facility for isolation or for admission, then you had to be COVID positive. But now this is not mandatory. If you are having symptoms and you want to isolate yourself from your home, if your home is not adequately big and you want to isolate yourself from home, then you need not to be COVID positive for getting admitted to the COVID health facility. A suspect case shall be admitted to the suspected ward of COVID care center, DCHC and DHC as a case may be. No patient will be refused service on any count, including medication such as oxygen or essential drugs. Now let's talk about management of COVID-19 at facility center. Ma'am had already talked about all the details. If the women is in antenatal period, if the women is in
Just 1 second. Kindly give us some time. We are trying to connect it again.
Anila?
Yes, ma'am.
Okay, please remove your slide so that I can
Okay,
see
ma'am.
the slide.
Okay, ma'am.
It's my
Mr.
slides are
Verma.
visible.
Yes, ma'am.
Okay, so sorry for interruption. There is a technical glitch. So I would like to continue with my presentation. So let's talk about management of COVID-19 at facility center. As I was saying, Dr. Inu had already talked about all the care during antenatal, internatal and postnatal period. So let's talk about management at COVID-19 at the facility center. So here are some of the guidelines, guiding principles of care for care of pregnant women in COVID pandemic. So all pregnant women, irrespective of COVID status, whether she is positive, she is COVID negative, should have access to women-centered, respectful, skilled care. Birth preparedness needs to be ensured. All pregnant women to be screened at the triage area. So before she goes for labor room, she has to be screened at the triage area. Testing criteria should be notified by ICMR and it must be followed. And testing criteria has to be followed only of ICMR. Then delivery services to continue to be provided in all facility. Already I have discussed that no mother should be denied of care irrespective of whether that hospital or the healthcare facility is having COVID center or not. All delivery points are advised to have isolation area and preferably a separate labor room. And OT for pregnant women suspected with COVID infection, septic labor room and OT, if available, may be utilized for this purpose. If a COVID suspected or positive pregnant woman in intermittent labor arrives at any non-COVID facility, she should not be denied service and be delivered at that facility itself. Then blood banks, blood storage units needs to be kept functional wherever it is available. So it is emphasized that maternity service are essential and adequate staffing labor room and maternity OT is paramount to maintain quality maternal and newborn health services. So whichever area or health centers are not there, they have to be equipped with labor room and maternity OT and adequate amount of staff should be there. Now we were talking about triaging. So any pregnant women seeking healthcare service shall be screened at the triage of a hospital or health facility to minimize contact between suspected COVID-19 and non-COVID-19 patient or pregnant women at health facility, because you don't know whether in the health facility a woman comes to labor room, whether she is COVID positive, she is suspected or she is non-COVID positive. So they should be screened at a triage center. A triage area should be set up before entry into the labor room. So a woman before entering her in the labor room, a triage area should be there. Triaging should be done using a checklist which can segregate pregnant women into 3 categories, that is screen negative, COVID suspect and COVID positive. So this is a suggestive checklist which is given by ICMR, that this checklist should contain name, wife of, age, gestational age, phone number, address, and there are certain questions which has to be answered by the women. Does the pregnant woman present with the following: fever with cough, fever with shortness of breath, past history of fever with cough or shortness of breath, history of contact with COVID patient, the patient in the healthcare worker is a healthcare worker. Question number 2, is the pregnant woman asymptomatic but a high risk contact, that is living in the same household with COVID positive, healthcare worker providing care at COVID positive, traveling with COVID positive. And the third question is, does the Pregnant women belongs to hotspot clusters, large migration gathering, evacuate centers and presenting symptoms like fever, cough, sore throat, runny nose, etc. So if any of these answer of the above is yes, then pregnant women to be sent to suspect ward and samples sent for testing or referred to higher centers. If all answers are no, patient to be sent to labor room. Algorithms for triage. Organization of facility for pregnant women. Then triage area before entry into the labor room. Then the women, if screened negative, whatever the questions in the screening or checklist was there, if in that she is screened negative, then we have to manage her as a routine pregnant women case. If she is COVID suspect, that means if any of the symptoms are there, then isolate in a suspect area, send sample for testing. If in immediate labor, preferably deliver in pre-identified labor room. She should not be mixed with other in the labor room. So a separate labor room which is pre-identified should be there. Then COVID positive pregnant women, then refer to the dedicated COVID health center depending on severity of illness. If in advanced labor, deliver preferably in a pre-designed labor room. ANC with mild, asymptomatic, pre-symptomatic and not in labor may be home isolated. So if she is positive and if there is no as such symptoms, then she should be isolated at home only. Now we'll talk about place of triaging. The place of triaging, it should be situated close to the main entrance. If we are talking about labor room, then it should be at the entrance of the labor room. Should be spacious enough place for the health workers to work and interact with pregnant women, maintaining safe distance with all precautions. The place should have a waiting area for women to sit with social distancing and should have examination area with table and fully equipped trolley. A mechanism for proper referral of pregnant women in case she cannot manage at same facility by ensuring the availability of referral transport using 102 or 108 or other modes of transport as per state's provision depending on the severity of the symptoms of the women. Then if the woman is screened negative, she should be managed as routine case and the testing in this patient should be as standard protocol if the symptom persists. Then COVID suspect pregnant women should be isolated in a suspect area and sample for testing should be sent. So if anyone or any women falls under COVID suspect, then that women should be isolated and should be kept in a separate area and the sample should be sent for test. Now, what are the challenges in triaging? Sometimes the pregnant women comes in our triaging and because of fear, she say that she is not having any symptoms and she will be triaged non-negative. So it is emphasized that healthcare workers should consider all patients including pregnant women as potential carrier of COVID-19 and hence should follow all standard precautions for their own safety. This is for the safety of the healthcare professionals because sometimes the women, as I have already said, may not disclose the symptoms and the safety of the other pregnant women admitted in the facility. So assessing disease severity in pregnancy and management. If the pregnant woman is asymptomatic, then the signs and symptoms, positive COVID-19 test results with no symptoms, or if the person is mild with the flu-like symptoms, that is fever, cough, myalgia or anosmia, then assess comorbidities, obstetric complications, high fever risk of developing severe disease based on history and examination, and if it is there, then the patient with no symptoms should be sent for home isolation, and if women are having some comorbidities, then it should be managed inpatient. Then moderate disease, the women will have dyspnea, chest imaging compatible with pneumonia, that is SpO2 more than 94% on room air, fever more than 39 centigrade or 102.2 Fahrenheit, which will be unresponsive to acetaminophen, then that women should be admitted in the ward. Severe disease, that is respiratory rate more than 30 per minute, SpO2 less than 94%, chest imaging showing more than 50% of the lung involvement, that should be immediately admitted in ICU. And critical disease, that is multi-organ failure, shock respiratory failure requiring mechanical ventilation or high flow nasal cannula, then those patients has to be immediately admitted in ICU. Now let's talk about COVID-19 vaccination. When the vaccination rolled out in many countries, many women, especially the pregnant or the lactating women, were in very much dilemma whether they can take COVID-19 vaccine or not. So let's talk about it. Based on the recommendations from National Technical Advisory Group on Immunization, Ministry of Health and Family Welfare has approved vaccination for lactating as well as pregnant women against COVID-19 on 19th May and 2nd July 2021 respectively. So to help pregnant women make an informed decision to be vaccinated, they should be provided with information about certain things. So if pregnant women are in dilemma, we have to provide information that the risk of COVID-19 infection in pregnancy, the benefit of vaccination, we have to inform that the benefit of vaccine is very much if they are pregnant. Then along with the likely side effect of vaccination, there will be certain side effects like some people will have fever, some people will have headache. So that also has to be informed to them so that after vaccination they should not have or they should not go into panic situation if they have certain side effects. So based on the information provided, pregnant women will have the choice to take the vaccination. Now, as I have already discussed, many of the women said that whether it is safe to have the COVID-19 vaccine if I am pregnant. Yes, there is no known risk associated with non-live vaccine such as Pfizer. The vaccine used do not cause COVID-19 infection in mother or their Anila. Hello.
Yes, ma'am.
Hello. Anila, I think someone is using the desktop.
It's not me.
Can you please talk to IT because someone is using this one?
Okay, ma'am.
Okay. Okay, sorry. The vaccine used do not cause COVID-19 infection in mother or their unborn child. So it is safe. Expectant mother should be vaccinated when risk of exposure is high. That means if the woman is a frontline worker, then she should be vaccinated immediately, or they have underlying conditions such as hypertension or asthma, then the women have to take vaccine immediately because they are falling under high risk group and high risk group should take vaccination immediately. So what are the timing of vaccination? Pregnant women who opt for vaccination could be vaccinated at any time of the pregnancy. In case a woman has been infected with COVID-19 infection during the current pregnancy, she should be vaccinated soon after the delivery. But we should always follow latest advisory of Ministry of Health and Family Welfare on duration of gap between the doses, which may be updated from time to time. As we have earlier seen, the duration between the gap of first and the second dose was much less, but afterwards it has been changed to 12 to 16 weeks, and the precautionary dose is after 9 months of the second dose. So it is changing time and again, so we have to follow the guidelines of the MOHFW. Then coming to contraindications of COVID-19 vaccination. In the context of current scenario of the SARS-CoV-2 pandemic, experts have suggested that the COVID-19 vaccine may be offered to the pregnant women if no contraindication exists. Contraindications like if they are COVID positive within 3 months, then they should not take vaccines within that 3 months. Those are the contraindication. If it is not there, then she should take vaccine. Coming to registration for COVID-19 vaccination, it is same as other people. The modality of registration of beneficiaries, reporting of vaccination, generation of certificates, etc. remains the same as of general population. All pregnant women needs to register themselves on CoWIN portal, or if they are not registering themselves, when they go to the COVID-19 vaccination center, there should be registered. If the pregnant woman decides to get vaccinated, the process of registration for COVID-19 vaccination needs to be explained to her and the accompanying family member. She also needs to be informed about the nearest COVID vaccination center by whoever is knowing about it, so that she can, without any problem, she can go there and get herself vaccinated. Now, what are the precautions after vaccination? Pregnant women and her family member must be counseled to continue to practice COVID appropriate behaviors like wearing double mask, frequent hand washing, maintaining physical distance and avoiding crowded area to protect themselves and those around from spreading COVID-19 infection. So it is for everyone. So there is no requirement for screening of the vaccine recipient by rapid antigen test prior to COVID-19 vaccination. In some places, we might have heard that before the person is being vaccinated, they are doing RT test, but it is not recommended. Next, we have another question that I am a new mother, or just I have delivered a baby. Can I be close to my baby if I have COVID-19? Yes, close contact can help your baby to thrive, because if you leave your baby separately, there are certain complications which may arise. So your close contact is important. You should be supported to breastfeed early, exclusively and safely. Hold your baby skin to skin. Share a room with your baby after birth. Then another question we hear is, can I breastfeed my baby if I have COVID-19? Yes, the person or the mother has to breastfeed the baby early, and exclusive breastfeeding helps your baby to thrive. But we have to remember that the pregnant women should wear a mask, should follow hand washing before and after touching your baby. If she feels like sneezing, sneeze in your bent elbow or use a tissue to cover your mouth and nose. Dispose the tissue immediately after use, and routinely she has to clean the crib or cradle of her baby. Why she has to breastfeed the baby even though if she is COVID positive? Because breast milk, it is one of the best source of nutrition of most infant, and it provides protection against many illnesses including infection of the ear, lungs and digestive system. Breastfeeding is also associated with decreased risk of childhood obesity as well as specific autoimmune disease, allergic condition, childhood cancer and sudden infant death syndromes. So if the mother is COVID positive, she should not feel restricted to breastfeed her baby, provided she followed the COVID appropriate behavior. Then almost all scientific bodies and organizations continues to recommend that mother with suspected or confirmed COVID-19 should be encouraged to initiate or continue breastfeeding. Then the other question we get is, if I'm COVID-19 vaccine, if I'm should I get COVID-19 vaccine if I'm breastfeeding? Yes, there is no known risk associated with non-live vaccine, and all the vaccines till date is non-live vaccines for COVID-19. So these vaccines for breastfeeding and the infant doesn't receive any antigen from the breast milk. Breastfeeding mothers who are frontline workers and who are vulnerable should be offered COVID-19 vaccine immediately. So all vaccinated mother must continue to wear face covering, social distancing and hand washing regularly to reduce the spread of COVID-19. So if you are breastfeeding, you should get vaccinated against COVID-19 as soon as it is your turn. So none of the current COVID-19 vaccine I have already discussed have live vaccine which can be transmitted to the baby through breast milk. And in fact, the antibodies you get after vaccination may go to your baby through vaccines. So baby will get antibody. If the mother is too unwell to breastfeed her baby due to COVID-19 or other complications, she can be supported to safely provide her baby with breast milk in a way possible and acceptable to her, such as expressing breast milk, donor milk, wet nursing, that is breastfeeding by another woman, and or infant formula milk with safe measures. So coming to conclusion, the COVID-19 pandemic has been the biggest global public health crisis in this century, and it will long last in the world. The COVID-19 pandemic had a drastic impact on both reproductive and perinatal health. But we hear that women have lots of misinformation and misconception about pregnancy, lactation, and vaccines during COVID-19. So there's absolutely no problem in going ahead and getting themselves vaccinated if the woman is pregnant, if she is lactating, or if she is breastfeeding. So it's probably the right thing to do at present situation by all the pregnant women or the lactating mother. So as a nurse, we have to encourage all the pregnant women for breastfeeding, for vaccination, and taking care of our baby, and we have to give them the moral support so that the pregnant women will not be having any problem during the time of pregnancy and delivery. With this, I end my topic, and these are my references. If anyone wants to know more about it or change in the latest guideline, you can go in this website and check the latest guidelines as and when it is changing. Thank you.
Thank you so much for your excellent coverage of the topic. I'm definitely this is information to my friends who are pregnant, and I hope everyone is benefiting. Thank you so much, madam.
Thank you,
Okay,
Anila.
so, let's move on to the discussion session. Okay, if there's any queries or questions that you would like to ask to our experts, they will be more than happy to answer your questions today. So let me see if there's any questions in the chat box. We have few questions here. Okay, let me read out. Okay. Can mother breastfeed her baby if she is COVID positive? I think this has been answered by Madam Binita. So if you need any further clarification, ma'am, if you would like to give any further clarification on this, you can highlight, or else it has been answered already.
Yes, if the mother is COVID positive, the guideline says that she should not be afraid to give breastfeeding to her baby, but she has to follow all the COVID appropriate behavior like wearing mask, washing her hand before touching the baby, and after touching the baby also she has to wash her hand. So without hesitation she can go for breastfeeding.
Okay, thank you, madam. So we have a next question here. Should mother with COVID-19 be separated from the newborn? I think this has also been answered already.
Yes, already I have said, because again, if you separate the baby, later on there will be some problem. So we should not separate the baby. The mother and the baby should be kept in the same room. Mother can take care of the baby unless mother is severely ill. Again, the mother has to follow COVID appropriate behavior.
Thank you, ma'am. Okay, so we have one more question. How should the newborn be evaluated? I think Madam Inu would like to answer. How should the newborn be evaluated?
Okay, newborn of the COVID positive mother.
But it's just written newborn be evaluated. Maybe I think it's a COVID positive mother. How can the newborn be evaluated? I think Inu ma'am's mic is mute. Ma'am, can you unmute your mic, please?
Ma'am, you are on mute.
I think ma'am is not being able to unmute.
I think from the
Ma'am, we have already informed the IT department. Ma'am, I think they're working on it, ma'am.
okay. Okay, any other question by that time, Anila?
We just have 3 questions. If you all have any questions or any queries, you can still post it in the chat box. Okay. Yes, ma'am. Ma'am, you can unmute your mic now. It's working.
Yes.
Yes, ma'am.
Okay, can you tell me my research questions? What they have asked?
How should the newborn be evaluated?
Actually, soon after, like if the mother is COVID positive, that time we have to like check for baby also at the same time, like whether that baby also might be suffered from COVID positive. So in the same way, we have to evaluate baby after assessment.
Thank you so much, madam. Since there are no more questions in the chat box, I hope all the queries has been answered by our experts. So thank you for the clarification, madam. So now we have come to the end of the webinar. So on behalf of Sikkim Manipal College of Nursing, I'm glad to be here to express my word of thanks. A special thanks to our Dean, Sikkim Manipal University, for constantly supporting us and giving us the encouragement. Very grateful to our officiating principal, Madam, Professor Champa Sarma, for her guidance and support throughout. I'm extremely grateful to our resource person for having agreed to be the part of this webinar today. I would also like to thank our faculty, member of SMCON and the staff for their love and support. And how can I forget IT department of Sikkim Manipal University, especially to Mr. Vijay Gupta, without whom I believe that today's webinar would have not been possible. Last but not the least, I would like to thank all the participants for your presence. Because of your presence and your participation, we were able to take this event as a successful one. Thank you everyone and have a great evening.
Thank you, Anila.
Thank you.
Thank you, ma'am.
Thank you, ma'am.
Thank you, everyone, for giving me this opportunity in this platform to say a few words regarding COVID-19 and pregnancy. Thank you all.
Thank you, ma'am.
Thank you. Can I leave?
Yes, ma'am.
Yes, ma'am. So the certificate, the feedback, after the feedback has been filled, all the e-certificate will be sent 48 hours after this webinar.
Anila, feedback link is sent?
Yes, ma'am, it's shared already.
Okay. Okay, thank you. So we can leave, no?
Yes, ma'am. Thank you, everyone.
Thank you.
I can leave now, ma'am? Yes, you can leave.